other procedure. Main outcome measure was intraocular pressure, visual acuity, number of anti-glaucoma medications, complications, and complete success were secondary measures. phaco was done with foldable IOL, either 2.2 or 2.8 millimeter entry, and phaco ACPL followed, whereby the processes were targeted at the tip, and whitening and shrinkage was the endpoint. Baseline characteristics were very well matched in both the groups. A follow-up of about a year is available, and in phaco endocycloplasty group, as you can see, IOP, AGM, and were reduced, and BCVA improved. Sorry. And in the phaco alone group, it was only anti-glaucoma medication, and which was reduced. IOP did not reduce significantly. When there was a between group comparison, then I found that intraocular pressure and anti-glaucoma medication both were significantly reduced in the phaco endocycloplasty group, with a complete success of 77% in this group and only 20% in phaco alone group. Complications that were that occurred were not significant, but I would say significantly there was aqueous misdirection more in the phaco alone group. Therefore, lasering the tip of the ciliary process, what it does, it aids deepening of the anterior chamber, and therefore I feel that is why we don't get aqueous misdirection. One of the implications of continued usage of anti-glaucoma medications is, of course, continued risk of ocular surface disease, adherence, compliance issues, quality of life issues, and of course, cost implications. And aqueous misdirection has been described previously in phaco alone group. So I would conclude by saying that phaco endocycloplasty and phaco alone procedures are efficacious in lowering IOP and anti-glaucoma medication in mild to moderate angle closure glaucoma. However, phaco endocycloplasty does it more efficiently. Thank you.
So how many quadrants did you do this endocyclo? How many clock hours?
Yeah, about 2 quadrants. I actually go by number of processes. So we are set to have about 60 to 62, maybe 65 ciliary processes, and I target about 30 to 32. About half.
And what kind of laser settings were used?
Yeah, I start with a power of 500 milliwatts, and I reduce as per pops. My time is fixed at 2 seconds.
So this is endpoint is popping of the...
No, I wouldn't like popping. If I get popping, I do tend to get quite a bit of fibrin post-operatively, and that really does not help. So what I tend to do is, as soon as I get a pop, I reduce the power.
You said aqueous misdirection reduces after endocyclo.
No, what I'm trying to say is that we don't get aqueous. I have, so far in all the patients that I have done, I have not had a single aqueous misdirection, either intraoperatively or postoperatively. And what I have found is that it helps to deepen the AC further. I've done a study on this, an intraoperative OCT imaging.
And how many of patients with phaco alone had an aqueous misdirection?
3 eyes.
Thank you.
Thank you.
The next presenter is Dr. Geetanjali Sharma Bose. Next is Dr. Swati Upadhyay.
Yes, ma'am. This one. Shall I start? Good morning, respected judges and dear friends. So, I'm going to present my poster on outcomes of sutureless SFIOL with trabeculectomy in subluxated or dislocated lenses in glaucoma, and I have no conflict of interest or financial disclosures. Aphakia, as we know, is a crippling condition which can severely restrict the activities and lifestyles of affected individuals. And secondly, glaucoma is frequently associated complication. So, to deal with both, the most preferred choice will be posterior chamber intraocular lens. But in cases of lack of capsular support, either we do iris fixated or a scleral fixated IOL. So, and trabeculectomy still remains the gold standard for glaucoma. So, the purpose of this study was to evaluate the outcomes of combined mitomycin C augmented trabeculectomy with sutureless SFIL implantation in cases with subluxated or dislocated lenses with glaucoma, and secondary outcome was to compare the results of sutureless SFIL implantation performed by a glaucoma surgeon versus a vitreoretinal surgeon. This is a retrospective case series done between January 2015 and January 2020. Cases were analyzed, and all required permissions were taken. So we defined success in terms of vision as a logMAR BCV of less than 0.5, incomplete success logMAR BCV between 0.55 to 1, and failure of BCV more than 1 logMAR. Excuse me, the timer is running on its own, this slide. Success in terms of IOP was defined as complete success more than 6 or less than 21 millimeters of mercury without glaucoma medication. Qualified was with medication or with 5-fluorouracil. Complete failure was either hypotony less than 6 mm of Hg or greater than 21 millimeters of mercury. 27 eyes of 26 patients were analyzed with a mean age of 56.8 years, ranged between 23 to 74 years, and there was a positive history of trauma in 18 eyes, and there were male to female was 15:11, right eye to left eye was 13:14, and the median follow-up period was 6 months. We had secondary open angle glaucoma as the majority of cases, followed by secondary angle closure glaucoma. So these are the baseline parameters. IOP was a mean of 41.5 plus minus 9.3 and ranged from 28 to 58. BCVA was 0.9 to 0.7, and number of anti-glaucoma medication, 3 anti-glaucoma medications. There were 13 patients on 3, 8 patients on 2, and 6 patients on 1. At final visit, 19 patients were off the medications, and it was statistically significant. So we used scleral patch graft in one eye, and there was vitreous hemorrhage on POD 1 and 5, and hypotony on POD 1 was there in 4 because vitrectomy was done along with the trab. 5FE was given in 2 patients, AGM was given in 2, blood massage was done in 4, and LSL was done in 5. Late post-op complications were RD, ILM, NVG, ERM, all 1-1 cases. So this is terms in success in terms of IOP. We got 70.4% success in terms of IOP, and it's 66.6% complete success in terms of vision. Between vitreoretinal surgeon and glaucoma surgeon, there was no statistically significant difference with the SFIL implantation. So our study shows a 70.4% success in terms of IOP and 71 as compared to David et al., who also have 71% reported success. Complete success in terms of vision was seen in 66.6%, and the lower rate of complications in our study was due to the use of sutureless SFIOL implantation by both anterior and posterior segment surgeons. Visual outcomes were comparable. So the strength is we bring forth the outcomes of sutureless SFIL either by handshake or X-net technique and compare the outcomes between glaucoma surgeon versus vitreoretinal surgeon. Limitations being it retrospective study, small sample size, short-term follow-up. So to conclude, trabeculectomy with sutureless SFIL is a safe and effective technique for treatment of glaucoma and aphakia. X-net technique is a time-saving, less expensive and easy-to-learn technique with visual outcomes at par with vitreoretinal surgeon performing SFIL. Thank you, sir.
So did you use the Yamane technique for SFIL?
No, sir. We used a 24 gauge needle to make scleral tracks, and then we inserted the haptics into the scleral tracks.
Okay.
Thank you, sir.
Next is Dr. Shayana Bumbla. Dr. Ananya Datta.
First one. Oh, it's not.
Good morning, respected judges. I shall be presenting on the comparison of vessel density values using OCT angiography and RNFL in POAG and glaucoma suspect patients. The ONH vasculature dysfunction is believed to be a contributing factor in the development of glaucoma. Thus, what we need is a reliable, reproducible clinical method for early detection and monitoring. OCT angiography is a new method for analysis based on high-resolution, non-invasive technique, whereby retinal, choroidal, and optic nerve head circulation can be visualized without the need of dye. Our aim was to evaluate association between vessel density measurement using OCT angio and RNFL analysis in POAG and glaucoma suspect. It was a cross-sectional observational study, and data was collected from diagnosed cases of POAG and glaucoma suspects attending the glaucoma clinic and healthy eyes fulfilling the criteria. Our sample size was 120, 40 each in the 3 groups. Inclusion criteria was more than 18 years old, open idocorneal angle, and BCV of minimum 0.48 logMAR units. Exclusion, no history of intraocular surgery except glaucoma and cataract. Secondary causes of glaucoma were excluded. Non-glaucomatous optic neuropathies, vascular and non-vascular retinopathies, and other ocular systemic diseases were excluded. After taking proper consent, a detailed history was taken and examination was done in the following way. UCVA, BCVA followed by anterior segment, IOP with GAD and CCT measurement, gonioscopy, HFA, fundus examination, then OCT, RNFL and ONH, and ONH angiography using Cirrus HD OCT 5000. This is one of our glaucoma suspect patients with IOP26 CDR ratio 0.6 with with normal visual field test. The first one is showing the inherent perfusion density in percentage and flux index. The B diagram is showing RNFL thickness in microns in the 4 quadrants. And this is the pictorial representation of the vessel density, which was converted to fractal dimension image by box counting method and by using the MATLAB software. Our results, we compared the 2 parameters. We found an increasing trend from POAG to healthy, and the ANOVA test showed a significant ratio in both. And we compared pairwise post-hoc tests for bonfirinis and found it significant in POAG versus healthy and suspect versus healthy. For diagnostic accuracy, we ran a ROC curve, that is the receiver's operating curve, between POAG and healthy, glaucoma suspect and healthy, and POAG glaucoma suspect. The red line here signifies vessel density, while the blue line is OCT RNFL. In the first curve, we can see that both vessel density and RNFL are performing similarly, while in glaucoma suspect and healthy, we can see that the vessel density is outperforming RNFL. In POAG and glaucoma suspect, RNFL is doing a much better job. We compared our study with Yar Muhammad Ali et al., whose findings were quite similar to ours. And Triolo said that RNFL is better diagnostical ability and put forward the hypothesis that neurodegeneration is more prominent than microvascular degeneration. In conclusion, RNFL has better diagnostic capability in differentiating glaucoma from healthy eyes. However, OCT angiography was found to be better in screening out glaucoma suspects from healthy. Thank you.
Just go back and show the AIOC. Can you just show that slide again? Don't switch off. Yeah, thank you.
We took 0.750 as the base.
No, just one thing. Your AUROC for POAG versus healthy, OCTA VD is 0.86. And glaucoma suspects versus healthy is 0.918. It's little unusual. The definite glaucoma should have a better AUROC compared to the glaucoma suspect. Usually by tradition, because definite glaucoma is more RNFL loss, more structural
Yes, sir.
changes as opposed to the suspect.
Yes,
So can you just
So that is what was our confusion, because when we compared it with other, this was like Yar Muhammad Ali's comparison, they found both of them to be significant. When
I am not talking about that.
Yeah,
I
wait.
understand. First of all, significant 0.9 is decent enough.
Yes,
But
sir.
I am saying that the POAG AUROC curve is little inferior compared to glaucoma suspect versus
So
healthy.
our conclusion in this
I
was,
am not talking about conclusion. Now I am showing you the data.
yes, sir.
I am asking you a question related to the data. So I am not bothered about conclusion. Every person can conclude what they feel appropriate based on the data. The question you have to answer now is that why this discrepancy?
So
Either
in,
there is any scientific logic or is just the data variation.
so in POHE versus healthy, VD and RNFL is almost performing the same way. But in glaucoma suspect and healthy, the vessel density is showing quite this one. For maybe neurodegeneration is a later stage of microvascular.
No problem. Thanks. And second, when your study design is POAG and glaucoma suspect, your inclusion criteria should not be the standard like 18 years. So we should be 40 years plus to start with. Okay. There is no point having 18 year plus because POAG by definition is 40 year plus because otherwise you will diagnose as juvenile open angle glaucoma. Okay. And for control also, it should be age matched. So there is no point taking controls who are younger, and if you're not age matched, then there is a flaw in study design.
Yes.
Okay?
Thank you. Next is Dr. Namrata Shri. Next is Dr. Ruchi Budat. Dr. Tanya Ray.
So far we are doing 50-50.
एक बार इसको इसको दबाना होगा ना दिस वन ना या ओके ओके थैंक यू ओके सर कैन आई स्टार्ट Good morning. Today my topic is on prospective evaluation of the wipeout after glaucoma filtration surgeries in eyes with a split fixation. I have no financial interest. Wipeout is defined as an idiopathic loss of central visual field with a retinal sensitivity measures as in 0 decibel in the 4-point averting the fixation both on central 10-2 and the macular threshold program associated with decrease in the visual acuity 2 lines or more. Risk factor preoperative split fixation, postoperative hypotonia and the pressure spikes, mode of anesthesia, retrobulbar and the peribulbar, and history of coronary artery disease. Incidence 0.95 to 13.6% in eyes with an advanced glaucoma. So the aim of the study to evaluate the incidence and the etiology of the visual loss in early postoperative period after glaucoma filtration surgeries in eyes with a split fixation. Method, it is an hospital-based prospective interventional studies. Informed consent was taken and they approved by the Ethics Committee of Institutions. 15 eyes underwent trabeculectomy with mitomycin C in Group A, and the 15 eyes combined phacotrab with an mitomycin C, Group B. And the period of study, March 2020 to the March 2021 in RIO Kolkata. Inclusion criteria, patient with an advanced glaucomatous field with a macular split fixation. Exclusion, patient visual acuity was too poor, undergo visual field examination, and and patient with a central vision loss due to retinal or neurological pathologies other than the glaucoma. Now come to the follow-up and the outcome. Patient was examined first 14th and then after 1 month, and final examination at the end of the 2 months, and each visit best corrected visual acuity, IOP, number of anti-glaucoma medication, and the postoperative complication were noted. And the main outcome, including the incidence and the etiology of the visual loss, changes in the IOP, best corrected visual acuity, and the visual field indices first 2 months after surgery. So now come to the baseline characteristic. The mean number of quadrant of split fixation in group A is 1.33, where in group B 1.53, and the mean deviation in group A minus 24.17, where in group B is a minus 24.34. Now come to the changes in the IOP. Both the group, there is a significant drop of IOP in the post-op periods, and changes in the visual acuity. There is a sudden drop of visual acuities in both the eyes, and then stable after two months. So now come to the postoperative data, and the postoperative visual field indices is compared with the preoperative value, and that was statistically non-significant. Now the scatter plot comparing the pre-op mean deviation with the post-op after 2 months in group A and the group B, and that was statistically non-significant. And the post-op complication in group A, 1 patient developed choroidal detachment and the 1 patient developed cataractus changes, wherein the group B, the 1 patient developed choroidal detachments. Now come to the discussions. There is a prospective evaluations of the early visual loss by glaucoma filtration surgeries in eyes with a split fixation by Dr. B. Shanta et al. The incidence of the unexplained visual loss was none. In my studies, none of the eyes showed the wipeouts. So the conclusion, wipeout is an idiopathic and the irreversible loss of vision after glaucoma filtration surgeries. In advanced glaucoma is a rare occurrence and the most often occurs due to the reversible cause. So the surgery should not be withheld due to the risk of wipeout when the intraocular pressure cannot be maintained medically in advanced stage of glaucoma. References? Thank you.
How exactly you defined the wipeout?
Huh?
The definition.
Huh.
There are various definition in the literature. So which one you used?
Yeah, we defined wipeout as a loss of central visual field. Within macular central visual field is a 10-2. The 1 point near to the fixation is 0, or in macular threshold studies, any quadrant, at least one quadrant, all the points should be 0.
Which program? When you said macula and 10 days to which size?
Better
size
is a
3,
macular
size
threshold
5,
strategy, confirmed by the macular thresholds.
Size 3, size 5.
Size 3.
Because the size 5 is a better way of doing when you say, because most of the literature which has used 10 days 2 and size 3 macula is overestimated. What you said is absolutely right, is very rare. But the literature which has used size 3 and macula program is overestimated. If you do the size 5, really, when you have a 1 split or 0 on 10 days 2, you must confirm by size 5 macula. That is a better way of doing, and that is what the literature defines nowadays, split fixation. Not on 10 days 2, not on size 3. So most of the patients did not have split fixation in your study to start with. Okay?
Yes, sir.
Thank you. Dr. Lopamudra Biswal.
Good morning, everyone. Today's my topic is on detection of macular ganglion cell loss in ocular hypertension, primary open-angle glaucoma suspect, and primary open-angle glaucoma by spectral domain OCT. Glaucoma characteristically affect the innermost 3 retinal layers. The macula contains the maximum number of retinal ganglion cells, so the detection of macular ganglion cell loss can be helpful in diagnosing glaucoma. The spectral domain OCT of Zeiss Cirrus ST-ACT has a GC algorithm which segments out RNFL and measures the GC-IPL. The primary objective of our study is to detect the macular ganglion cell loss in ocular hypertension, primary open-angle glaucoma suspects, and primary open-angle glaucoma patients. The secondary objective is to know which part of the macular ganglion cell loss is affected first, whether superior or inferior, whether detection of GC-IPL is superior to the parafoveal RNFL in diagnosing glaucoma among OHT, POS, and POG patients. It is a prospective observational study conducted at Arvind Eye Hospital, Tirunelveli, over a period of 18 months with a sample size of 112. The study population includes primary open-angle glaucoma patients, ocular hypertensive, primary open-angle glaucoma suspect, and normal population. Basic ophthalmological examination done. All OCT scans are done using Cirrus ST OCT system. OCT with signal strength of 6 or more were taken. The mean GC-IPL thickness in each quadrant and the average superior and inferior GC-IPL were recorded. Also, the mean RNFL thickness were taken. Coming to the results, the age distribution shows the patients with primary open-angle glaucoma were older than the other 3 groups. There is no difference in male and female population among the 4 groups. Coming to the comparison of the superior GC-IPL, the superior GC-IPL is significantly thinner in primary open-angle glaucoma patients compared to OHT, POS, and normal, and there is no significant difference among the 3 groups. Similarly, the inferior GC-IPL is significantly thinner in primary open-angle glaucoma patients compared to OHT, POS, and normal, but there is no significant difference among the other 3 groups. But the RNFL is significantly thinner among OHT and normal, POS and normal, and POG and other 3 groups. This is the receiver operating characteristics analysis of average RNFL, superior GC-IPL, and inferior GC-IPL. The average RNFL had a significantly greater ARSC value compared to superior and inferior GC-IPL from distinguishing OHT versus normal and POS versus normal. But the average RNFL, superior and inferior GC-IPL had maximum ARSC value closer to 1 from distinguishing primary open-angle glaucoma versus normal as shown in the pictures below. So to conclude, there is a significant thinning in GC-IPL noted between POAG and OHT, POS, and normal. No significant GC-IPL loss noted between OHT, POS, and normal. The inferior part of the macular ganglion cell layer is affected earlier than the superior. The RNFL and GC-IPL parameters have same diagnostic capability in primary open-angle glaucoma patients, but in POS and OHT, the RNFL changes occurs earlier than the GC-IPL. So the GC-IPL appears to have a role in monitoring the progression of established glaucoma. Thank you.
So what was the gap in the literature that you were trying to explore?
Sir?
What was the gap or what was the lacunae in the literature that you had?
Sir, certain studies have shown the GC-IPL picks up earlier in also OHT and POAG. But we found that in primary open-angle glaucoma, only the GC-IPL is thinner compared to the other 3 groups, but there is no significant difference among OHT, normal, and POS. But the RNFL picks up earlier in OHT and POS compared to normal.
How much was your cutoff for GCL-IPL thinning to be considered as significant?
How much?
How much was your thinning of GCL-IPL to be considered as significant enough to be considered as thinning?
Sir, less than 85 like that we have taken. 80 to 85. Thank you.
Is Dr. Sanchita Agarwal here? Dr. Gitanjali Sharma Bose? Dr. Shayana Bumla? Dr. Ruchi Budat? We're done with this session. Thank you very much for your attendance. The first one.
not just, yes, yes. So there is no confusion.